On behalf of the Stern Healthcare Association, I'd like to thank you for coming out tonight. I'd like to introduce Anthony Manson and Health 2.0.
Okay, thank you everybody. We're really happy that you can join us this evening. This is a very, very important event, and I'm really excited that you can be here. I want to thank a lot of people that helped make this event come to be. And most importantly, as I said, this is an important event because mental health is important. It doesn't get enough venture funding. It doesn't get enough attention in the business sector, and we need to change that. And Craig DeLarge, who is my co-organizer, who's been fantastic at pulling this event off with me. We have been talking for almost a year now about this, I believe, and saying how critical this is that we do something and we start to get energy and traction for companies that have great ideas to help solve some of the mental health issues that we have in our society today. And it's really troubling if you look at what's going on in the world, and if you look at the statistics, it really kind of dumbfounds yourself as to what's going on here. It just doesn't make sense. You know, there's just not enough providers out there to handle the tremendous load. There's so many undiagnosed, so many untreated people that are suffering, and we have to do something about it. So this event is important. You know, it's important because if you think about it, there, you know, not just suicide, but the amount of lost productivity due to depression, it adds up to about $51 billion of lost productivity. It's the #1 cause of sickness and sick days off at companies across the country. And that, you know, that affects all of us. And mental health affects, we have friends, we have family, it impacts everybody. The one event that struck in my town was one of the best third grade teachers that my children had, who they still talk about, Miss Elise Draper, committed suicide with 2 great kids, beautiful family. You know, you would have thought she had the world on the tip of her hands, and it just happens. So that's why we're here today. This is important. So let me get started. I'm going to go over the agenda a little bit just so you know what we're going to do. We're going to start out with, jump right into 6 pitches. We have an all-star judging panel that will be introduced in a minute. And each one's going to get 5 minutes to pitch, and there'll be a 5-minute Q&A. And then each one will be scored based on criteria, and then we'll announce the winner at the end. And then we'll have some networking time left at the end so that you can continue to converse and discuss. And then we'll have an after party around the corner. So we'll tell people on your way out. So if you want to continue to network, you can. And most importantly, I really want to thank the sponsors of this event because we couldn't have done it without them. #1 is NYU Stern Healthcare Association. So a huge thank you to David, Whitney, Rosie, everybody who's been tremendous in terms of hosting us and supporting us. And I think it's, you know, I'm reinvigorated to hear about what these students are up to and some of the great startups that they're doing. So keep tuned into what they're doing. Also, I would really want to thank Janssen Innovation, who is doing some amazing work in reinventing healthcare. And so there's some Janssen folks here tonight. Make sure you meet them and hear about what they're doing because it's great. Also, I want to thank HP Haven, which is the big data services for Hewlett-Packard. And they're doing some tremendous work, and one of their salespeople or reps will be here tonight. If you want to learn more about what Hewlett-Packard is doing in big data, talk to them. It's really impressive, and I think it's critical, and they're supporting. They want to support startups. I think that's the great thing we're seeing in New York City today is the big companies, Microsoft, HP, all of them really want to offer their services at very low cost to help startups get going. So don't hesitate to reach out to these big companies and think you can't afford them. I think you'll be surprised at how they're really willing to you know, roll up their sleeves and help you. I also want to thank Loeb & Loeb, and I want to really thank Dudnik. I'd like to introduce Beth to Heather to talk a little bit about Dudnik and what they offer. Heather?
Well, thank you. I'm Heather Aton. I am the Chief Innovation Officer at Dudnik Health. And I feel like having a role like this at a healthcare marketing and communications company is innovative in and of itself. We are very excited to be a sponsor of this event. It's a bit of an experiment for us. We've found that healthcare in general tends to be very traditional, and while there's incredible opportunity for innovation in the healthcare space, there's so much work to be done. So we are very proud to be sponsors tonight, really thrilled to be here. I do want to say we are really proud of our work in the past in mental health space and digital innovative solutions in particular for some of our past clients, and particularly proud of our current work with forward-thinking companies like Neuronetics, and that's ongoing right now. And I do want to congratulate our 6 finalists this evening. Really excited to see what lays ahead tonight. And I do want to especially thank Craig DeLarge for his leadership, partnership, and collaboration over the past several months. Thanks.
So my name is Craig DeLarge, and I'm the director of the Digital Mental Health Project. And so I can't thank all of you enough for taking time out of your busy schedules to be here this evening to participate in this event with us, where I won't belabor points that have been made much already, but this idea of figuring out how to leverage these technologies, digital technologies, to address a growing problem and challenge that we have as a society around mental health and mental illness is really important, where I found in the research that I've been doing in this area as a part of the Digital Mental Health Project that there is not a lack of applications that are being worked on, but very often what we have is a lack of adoption and scale up of these applications. A lot of it having to do with various types of digital divides that occur in the system and the society, concern over privacy, issues with accuracy around measurement of these technologies, and I would say most importantly, stigma and discrimination, which as I see it is that shadow element that if we don't address it as a larger society, all the technologies that we develop, people will be afraid to use them. And so I think it's really important that as we listen to the various companies tonight and the different technologies that are going to be presented, that we understand that in order for the technology to do the most for the most people in the society, hopefully not even for one of us one of these days, we've got to continue to do the work around stigma and discrimination that goes hand in hand with the technology. So that said, let me talk a bit about the rules for how this is going to go tonight. We actually had 27 companies that originally applied for this prize, and we narrowed it down to the 6 companies that you're going to see this evening. Each company will come forward. They will have 5 minutes to present, and then the judging panel will have 5 minutes to question them. Each of the judges have a scoring sheet that they will be filling out at the end of each round that will go to our master scorer, who is here in the room somewhere, I know. And then at the end of the evening, obviously we're going to be calculating and figuring out who the $10,000 in cash and prizes that we've been able to raise from the various sponsors will go to, okay? So that said, I want to give each of the judges a minute or less to introduce themselves, where we've worked very hard to get a good variety here. So on the panel tonight, we've got a venture capitalist, we've got 2 physicians, we've got a patient, because it's very important to have the voice of the patient in these types of forums. We've got an entrepreneur and a technologist. Okay, so starting with Dr. Davis. Very quick introduction. Yes.
Good evening, everyone. My name is Steve Davis. I'm a physician, psychiatrist. I see patients. I have a bunch of different hats. You said less than a minute.
Yeah.
I can't fit it all in, but I do patient care. I am the chief medical information officer for a mental health IT company. Thank you. In Rockville, Maryland, called M3 Information. We have a mental health screening and symptom tracking tool that covers depression, bipolar disorder, anxiety, PTSD, drug and alcohol abuse. It's used in primary care settings. I also do healthcare policy work. for the Maryland Psychiatric Society, and I chair the Committee on Mental Health Information Technology for the American Psychiatric Association.
Hi, my name is Todd Petrie. I'm general partner and co-founder of Milestone Venture Partners, a venture capital firm which invests in early-stage software and data businesses which solve problems in the healthcare ecosystem.
Hi, I'm Michael Cantor. I am an internist and associate professor at NYU Medical School of Medicine, excuse me. Before I came back to NYU, I worked at Pfizer for 6 years in healthcare informatics, and before that I was at Bellevue.
Hi, I'm Marta Edmiston. I'm a patient. I'm also a peer and family counselor. And I'm really excited to be here. I think this is so very important. And I've been searching and searching for good apps to use in my counseling. So this is really exciting for me. Thank you.
My name is Shola Mellenberg. I'm the CIO for JASA. I've spent my career, actually most of my career was working with startups, with a technology incubator up in Connecticut, and then with a technology firm in Lower Manhattan.
Hey everybody, good evening. My name is Samer Malik. I'm a co-founder and CEO at One Doc Way. We're a telepsychiatry company focused on improving access to psychiatric treatment in underserved communities across the country. And before this, I used to work in administration and behavioral health as well.
So our first company this evening is going to be Uplift. Who's here to present from Uplift Guided Track? Oh, here you go. All right. Yeah. Okay.
Just click that. How do I switch to the next slide?
Just to your page down.
At the end of the slide deck. Thank you.
Yeah, I think we should switch around here. We just stand. We can just stand on the side.
Yeah.
Okay, so all the chairs are out this way? Or just, okay. Okay, very nice. That's innovation in real time, right? Okay, very good.
All set? So I'm really glad to be here. I'm going to talk to you for 5 minutes about Uplift, which is our radical solution for a staggeringly large problem. And it's especially exciting for me to be here because we've never publicly talked about Uplift before, so that's really cool. So the problem that we're addressing is actually the #1 cause of years lost due to disability in the entire world. It directly afflicts 1 in 12 Americans. It causes way more than $17 billion in economic loss each year in the US. And of course, the problem I'm talking about here is depression. It ruins the lives of millions of people every year. So I want to talk to you about a couple facts that most people don't know about depression. The first is that it's actually known how to treat it using therapy. So CBT, also known as cognitive behavioral therapy, is the most evidence-based therapy that's ever been developed. It's been worked on for more than 50 years. There's over 100 randomized control trials that have studied its effectiveness. It works really, really well. And in fact, it has by far the most evidence of any therapy ever developed in history. The second really critical fact many people don't know is that most people who need treatment for depression don't get it. So right now, only about 50% of people with major depressive disorder get any treatment at all. And only 1 in 5 of those people get treatment that meets the American Psychological Association's guidelines. Now, there are many barriers that people have to getting therapy. There's the cost of it. There's the question of, will your insurance company cover it? How much will they cover? There's a lot of difficulty in finding therapists. People spend hours looking for the right therapist. They don't know what to pick. They may not have one in their area. And there's social stigma against seeing a therapist. So we've seen that A, depression is this incredibly big problem. B, there's a treatment that's known to work. But C, people don't get this treatment. So how do you solve this problem? Our solution is Uplift. It's a complete depression treatment program on your smartphone. It's fully automated, and it's comprehensive. That means it does with you the things that a cognitive behavioral therapist would do with you during treatment. It's a complete treatment course. You can start it instantly. You don't have to spend hours researching who to talk to. It's unlimitedly scalable. Once it's built, an unlimited number of people can use it. And it's incredibly low cost to use. We're thinking of offering it for about $10 for absolutely unlimited use, so the cost of maybe one copay. Our program's highly evidence-based, and it's highly adaptive. And that means we've really tried to stick as much as possible to the evidence for what works in treating depression. It's adaptive in the sense that each person is going to get different treatment based on exactly the kinds of problems they're dealing with. And it does things like assign homework, which is a critical part of cognitive behavioral therapy. Checks in on how the patient's doing. If they have trouble with their homework, helps them diagnose why they have problems and figure out how to do better next time. Of course, you might ask, can therapy actually be computerized? That's a big claim. Well, we have a big answer to that claim, which is there have been 19 randomized control trials studying computerized treatment for depression. These are actually the results. It actually really works. It's pretty incredible.
What's the scale of that?
Oh, that's Cohen's d. Cohen's d effect size. So it's a standardized effect size measure. OK, so how many automated comprehensive depression treatment programs are available on your phone right now? If you go on the iPhone store, if you go on the Android store. 0. There are no programs like this. And this is an incredible opportunity to help the world. So right now in the US, about 13 million people are clinically depressed and have smartphones. But if you don't just stop at the US and you look to the world, 131 million people in the world right now both have smartphones and are clinically depressed. And of course, this market's actually expanding. The penetration of smartphones for mobile phone users has just been growing dramatically and expected to continue to grow for years. We also think that there's huge partnership opportunities with this because, for example, groups that make screening tools for depression or that screen patients, they could refer people to our program. We could have revenue sharing with them. Insurance companies, we could help them reduce costs by offering our program. We can also refer out from our program to give even a better user experience. Telepsychiatry companies, we can refer people to them to get one-on-one treatment that really need it, or to therapist directories to help people find therapists in their area. So who's our team? Well, there's me. I've had 9 years of technology experience building a variety of different technologies in different areas. Our product lead wrote the largest ever systematic review on computerized treatments for depression. We've got a team of consultants who are people who specialize in CBT treatment, 2 software engineers building our technology platform, 5 editors and program testers. What's our progress like? Well, we've finished 2 years of development already on this project. Nearly the entire program content is now developed, and we're piloting it now on depressed people in about 4 to 6 months. That's it. Uplift for depression.
I had a question about the business model.
Sure.
You said $10. Is that $10 per month?
So we haven't fully settled on the price, but we're thinking $10 unlimited use.
Okay, because I think that having a recurring revenue model might be something you might want to think about.
Absolutely. That could make sense. I think we'll explore that. But we do really care about getting a large scale.
How do you think about distributing this? Is this going to be something you market to customers and patients directly, or are you going to be working with therapists and psychologists and psychiatrists to have them prescribe a treatment?
Yeah, we definitely want it to be available directly in the app stores because there's nothing like this that you can download in the app store, and we think that's really important. We also want to make partnerships with groups where we have there's a natural synergistic relationship where they could refer people to us, and it would just be mutually beneficial. So examples might be insurance companies where they have an incentive to try to reduce their costs.
Hi, are you thinking this is a sole mechanism for support or for treatment? Are you envisioning that this would only be used in conjunction with some
Yeah.
other form?
So that's a great question. So computerized treatments for depression have been found to be effective with sole use, which is really amazing. That being said, when you have really severely depressed people, you would want them to get into therapy as well, because that's going to be the maximally effective thing. So we want our program to actually push people out into seeing therapists when that's appropriate. For people with really low, mild depression, our program might be sufficient on its own.
One follow-up. I mean, are you envisioning this, or I guess it's already out there? Is there any voice recognition? Is it multiple choice? Is it
Oh yeah, so
texting?
it's not released yet. So we're beginning testing on depressed people in about 4 to 6 months. It's an interactive program. It asks you questions. Different things happen based on the way you answer. Images, text, video, things like that.
Multiple choice, basically.
Yeah, so it's a lot of it is multiple choice. The thing is, if you try to go like full AI system or free-form text responses, it tends to work very poorly.
Right.
Yeah.
Just do we have time? Okay. When you have somebody who this isn't working for, do you have like a trigger, or do you have kind of, fail-safe mechanisms? So I've been doing this for 3 months, you should see a therapist. How do you work that? And how do you prevent false positives on that, or negatives also?
Yeah, that's a good question. So that's really important. So one is that every session we check people for suicidality. This is super important, try to get them to emergency care. Our goal is not to keep people in the program, it's to get them better. And so whenever we think someone would do better in therapy, or do better using therapy in addition to our program, we're going to try to get them there. And that's why I think there's a lot of opportunity for connecting into other systems, like teletherapy systems, telepsychiatry systems, because then we can say, hey, look, you're not doing so well. Like, maybe you should consider going to this therapist in your area. Maybe you should consider this telepsychiatry program. Yeah.
And do people self-select, or how do you assess them to determine that they are depressed and this would be useful?
Oh, so when it's available in the App Store, anyone will be able to download it. We'll of course have different screening programs, PHQ-9, G87, things like that. That are sort of the most robust stuff that's known for self-report.
Thank you.
I think it's really smart of you to stay integrated within the other aspects of the behavioral health system. We've seen a lot of companies who try to be a standalone and solve it all and fail. So that's smart. I would encourage you to think hard about stickiness and patient engagement. That seems to be the other big pitfall for a lot of these apps or computerized therapy models, which is you can get patients to sign up on day one, but to see them through the course of completion is often very challenging.
I think that's absolutely right. And it's critical to focus on the user experience and making sure that people actually are engaged in the program. Ideally, you want them to actually enjoy using it. You want to add in systems that create sort of internal rewards for using it.
The other comment I had is that patients with depression, about 20% of them actually have bipolar disorder, so you need to have tools that make sure that you look for both of those things.
Absolutely. And my thinking on this is if we think someone has bipolar, we think our program's probably not appropriate for them, or at least not on its own. And so really we would want to get them to the appropriate providers.
The other comment is primary care providers treat the majority of people with depression. They just use primarily medications.
SSRIs, yeah.
When they can, they'll refer them to therapists, but it's hard to find therapists, A, that are in network that can be seen in a relatively short period of time, and B, that do a good job with CBT.
Yeah.
So how do you propose going after the primary care market?
That's a good question. So in the UK, they actually they use computerized treatments for depression. They actually have a program available to the UK citizens, which is interesting. Kind of, being the blues, it's one of the best systems there is. I think to start, we're going to focus on going direct to consumers, and then probably from there look to making larger partnerships with groups that would have an advantage of sending people to our system. We haven't developed yet a plan for primary care, but I think that is really important and something we need to think about.
The key will be outcome data to get any traction on this.
Okay, so we need to call time now, out of fairness to all the participants. Okay, no, you can keep that one. Okay, so thank you very much.
Thank you.
Good evening. I'm Matt Bars, CEO of IntelliQuit. Smoking is bad. You know that, I know that, and the world's 1.3 billion smokers know that. So do the 46 million smokers here in the United States. They know this so acutely that 70% want to quit, and every day, 65,000 Americans attempt to stop. As big as those numbers are, the vast majority of those who try to quit are unsuccessful. Only about 9% are able to reach their goal. And only, give or take, 12% of all smokers are ready to stop in the next 30 days. That's a tremendously untapped market. Smokers prefer, more than 50%, to cut down gradually. Meet IntelliQuit, the world's first smartphone biosensor for smokers. Similar to a weight scale for dieters or a blood glucometer for diabetics, IntelliQuit biochemically measures how much tobacco the smoker has actually consumed and transmits those results wirelessly via Bluetooth to the smoker's smartphone. So here we see the 46 million adult American smokers and the 22 million, which is our target market, those smokers 18 to 64, and the 65,000 who attempt every single day. But let's drill down to these numbers and see what we get, shall we? It turns out if you've been in the healthcare field, the mental health care field, for any more than 2 haircuts, I've been here more than 2 haircuts, you'll know that pretty much the vast majority of those who are psychiatrically challenged are cigarette smokers. 46% of all cigarettes bought in the United States are bought by somebody with a psychiatric disability. There is a strong dose-response relationship to the number of cigarettes smoked and suicidality. And schizophrenic patients report smoking 3 times more than the national average. So here we have the average adult smoking prevalence, and you can see that depending on diagnosis, prevalence ranges in terms of smokers from anywhere from about 60% to as high as 80+%. We feel that smoking is a tremendous signal for mental health issues. But despite what you may think, the vast majority of those smokers are ready to quit. 79% of depressed smokers intend to quit, and 24% of those are prepared to stop in the next 30 days. That's twice the national average for all smokers taken together. Alcoholic smokers are interested in stopping, and indeed they are successful if given the tools to do so. And perhaps more importantly, tobacco abstinence increases happiness and satisfaction with one's life, contrary to what is out there and the myths around tobacco treatment. So how does IntelliQuit work? Well, the individual smokes, obviously, and via expired breath, they blow into the IntelliQuit device, and that transmits those results wirelessly via Bluetooth. But that's not all. We have a suite of functionality which we're very impressed with, if I do say so myself. Medication adherence and e-pharmacy. Mobile games. This is you can see some of our characters for the Smoke the Zombie cigarettes, where zombie-like cigarettes try to kill you, you have to kill them first. In-app, real-time, real-world, mobile video coaching. Samir, we have to talk. Quantified smoker, so you can measure your progress, and GPS stamping, date, time, where in the real world you're actually smoking, so you can measure your progress and see where you're having difficulties. So what is our status? In the last year and a half, via Bootstrap and angel investment, our device patent is published and pending. We have our Gerber files complete. Our second prototype is complete. We have 2 proof of concept studies. Our first mobile app is also complete. We have interest from major medical centers and soft-circled written commitments for for over 700,000 units per year. Crushing mobile game is also complete, and contract discussions are in. We're done? Oh, I was just getting to the money part. All right.
So what it is that if you go over in your presentation, it cuts into your question time. So you do want to accelerate.
Okay.
To give the judges time to
Fair enough. I'll try to be laconic. Next slide, please. So, insurance policies are already reimbursing for the IntelliQuit suite of services. We're going for approval as a durable medical device. We have vertical markets in both B2B as well as direct-to-consumer. Retail price, $99. A monthly platinum plan of $17, again, reimbursed by insurance presently. Next slide, please. We'll be able to produce it for less than $33. I mentioned the standalone additional revenues, additional services, treatment support, ancillary products, flavored mouthpieces. You can actually flavor plastic. Did you know that? I didn't. But you can. Institutional sales to healthcare, government, big sale of big data to pharma. And I think I'm just going to end there. Thank you so much for your time. I'm happy to take questions, gentlemen and ladies.
I don't understand the rationale for measuring your carbon, for measuring this. I mean, you
Sure.
kind of know when you're smoking, and I guess, is it the numbers actually shock people that they have this level of carboxyhemoglobin, or what's the difference between this and second of all, what's the difference between this and, Chantix, or the effectiveness of this versus Chantix, Wellbutrin, and the other therapies that are out there?
This makes Chantix work better. This makes nicotine patches work better. If you're thinking that, well, you can just count your cigarettes and know where you're at. No, you can't, because of a phenomenon called compensatory smoking. You take somebody who smokes 30 cigarettes a day, put them in a situation where they can only smoke 5, you get compensatory smoking. The amount of nicotine you can pull out of the cigarette is extremely plastic. You can increase it threefold without any sweat whatsoever. So it's important to biochemically measure how you are doing. Yes, we are going to count how many cigarettes you need to do per day, but this actually tells you how much you're actually consuming. So the individual can see that. Yes, sir.
Can you talk more about the reimbursement? Is it the device itself that is reimbursable? Is it the service that comes along with it?
It's both. We do plan on applying as a durable medical device, so it would be picked up by insurance carriers, cost gratis minus whatever copay is necessary. But the services themselves, both for the expired breath, carboxyhemoglobin, that code is 94250. There are chronic care codes. There are psychiatric codes. There's, because we're measuring something, we can also bill for new patient, established patients on an ongoing basis. So the revenue stream is actually quite robust.
And just to follow up on that, do you envision being the service provider as well, or the platform through which service providers interact?
Both, depending on, as you probably and telemedicine regulations are pretty much all over the place. So where we can do both, we will do both. If we can partner with an institution and they just want to buy the units and do that themselves, we're certainly open to that as well. So we're going to look at all those models.
You talked about a lot of models to share the data and bring in partners. To me, the reading, whatever it is on the device, would be HIPAA, would be covered as PHI. Is that, I mean, are you planning to get a release from everybody to share the data?
Well, we don't plan on sharing personalized information. Everything that we're going to be doing is HIPAA compliant. So if an insurance company is interested in the number of people who successfully quit with Chantix,
so just summarize data,
exactly. We're not going to be selling the
anonymized.
individual. Right, exactly. Exactly.
Thanks. What sort of data or evidence you have from people who smoke that they would be interested in doing this? Do you have anything to suggest? It sounds like something
Yes.
that people would do, but then quickly peter out. So I'm wondering.
Well, actually, one of the pilot studies shows with a much larger predicate device. This is the device we have now. We wanted to get it about the size of a butane lighter, and this was what we were shooting for. We were not successful. We actually got it smaller. It's actually lighter than a butane lighter. So there is data. There's data from the UK. And there are 177 patients collecting data, over 90% compliance. There's studies using contingency management which show that over 97% of required carbon monoxides are done. The pilot study that I was referring to, 2 to 3 2 to 3 measurements per day was adequate to get a profile on where people were smoking, and they completed it again 97%. So folks like their numbers.
Make the other end of it a lighter. That way they'll never forget it.
That's not a bad idea.
Just quickly, so they are compliant, but are they stopping smoking?
Yes. I can tell you that they are. In fact, there are a number of data to show that. And in fact, the beauty of this is we will know if somebody is smoking or not by the numbers we get.
We can send you studies.
There are plenty of studies to indicate that, yes.
Okay, so we have to call time there.
Thank you. Thank you, everyone.
Hi, good evening. My name is Diana Jimenez, and he is my co-founder, Carlos Capellan. We're here to present Optimista. Optimista is a relationship management tool that helps school counselors in Colombia shift the focus from detecting mental health disorders to early intervention. So why are we here? Optimism is inspired by my brother. He has been suffering from mental health disorders for the last 13 years, and he was only diagnosed recently. My brother today, he dropped out of college. He lives an isolated life, and unfortunately, he has tried to commit suicide in many occasions. So what's the big problem? We found that my brother's experience is far too common. Mental health disorders begin in adolescence. There are long delays, sometimes up to decades, between the first onset of symptoms and when people successfully seek and receive treatment. Untreated mental health disorders are associated with more disabling conditions later in life, including crime, low educational achievement, and drug addiction. So we plan to bring Optimista to Colombia, to schools in Colombia where most adolescents are right now. In Colombia, schools are required to have a counselor by law. However, there is usually one counselor for 1,000 students or more. For this reason, many students that are at risk are falling through the cracks. I will let now my teammate Carlos Capellan explain to you our innovative solution to this social problem.
Thank you. So Optimista basically has 3 major components. First of all, we want to add the element of mental health screening and help that counselor detect mental health disorders, or the risk of mental health disorders in their student population. Second of all, we want to improve the relationship between the counselor and their students and facilitate that relationship by also providing continuity as counselors change over time. Finally, we want to be able to let that counselor analyze the data and understand trends in their student population and why certain groups might have elevated risk of disorders versus other groups. So we have a key partnership. We're working with Screening for Mental Health, which actually is very similar to Dr. Davis's company, which has been making mental health tests for about the last 20 years. And we don't want to reinvent the wheel, so we won't be working with them. We'll be using their test, their screening test, in our platform. So as we see it, Optimista is kind of at the center and is bundling together these 3 offerings into one cohesive platform for Colombian schools. The first piece, of course, is the screening. And we're working with SMH to bring their platform into our offering. The second piece is positive psychology coaching. And of course, positive psychology is a study of happiness, what makes us happy, and how to be more resilient in our lives. And we think this is so essential these days. So we want to take what you see in products like Happify and CoachMe and put that into our platform, build our own types of tests, gratitudes, goal setting, and those kinds of activities into our platform. Finally, of course, relationship analytics, kind of the Salesforce aspect where you can know your student population, understand trends over time, and understand exactly where the elevated risk lies. So let's look at the market opportunity in Colombia. There are 22,000 schools in Colombia, where we intend to launch first in Medellin. There are 759 public and private schools. And finally, in the private schools themselves, there are 259 schools that we want to focus on first. So we want to go to these private schools first, build our application, and try to perfect it, and then once you have a perfected application, go out to the other schools in the city. So why Medellin? Well, 3 reasons. First of all, as you can see right here, It was named in 2013 by Citigroup and the Wall Street Journal as the most innovative city in the world. Everything we've known about in the past has really changed. There's a dramatic shift in Medellin, the city. Second of all, it happens that Medellin has highest rate of mental health disorders in the country. We already know it's higher than the global average, but it's even worse in Medellin. And finally, what you see here in the picture is Ruta N, which is the incubator that the government of Medellin has built to foster innovation and entrepreneurship, including also a very healthy amount of funding for startups in Medellin. So, we will have a model where you subscribe. The school will pay an annual fee. We're going to be following a skimming strategy, where basically we're going to be first charging those innovator schools, those innovator private schools with the course who want to be the first and want to be the innovators and have larger budgets, work with them to perfect the tool. We'll then be dropping our price pretty aggressively as we move into all the way to the right where the public schools are. I don't know if you can see that so well there, but where the public schools are. And we're going to, at that point, we're really just trying to grab that market share and kind of have that kind of hockey stick growth. So just very quickly here, wrap up. So our social impact. We can measure at the macro level using disability-adjusted life years. As we all discussed before, it's a huge impact, and we can talk more in depth about this very quickly. At the micro level, we can talk about a baseline result over a survey over time and see how those student populations are changing in that screening test that we will be offering in the platform. So we have a fantastic team. Besides Dan and myself, we have 3 founders in Colombia who have excellent connections, excellent networks, and excellent talent. So we're really excited to bring the whole team together and make Optimista happen. Thank you. Sure.
Thank you. Can you talk a little bit more about how you're interacting with the counselors and therapists who are supposed to be engaging the students? So I understand the screen. I understand in some capacity you're giving a signal or raising a flag or identifying certain students, but where do you go from there? Are you a management tool? Are you a signal? How do you create that interaction?
Of course, it's an excellent question. Thank you. So if we just jump here to we have some wireframes here we're working on, but effectively what we're looking to do here is first of all make that counselor more effective, right? They just have so much to deal with 1,000 students. How do they even begin to understand the population? So first of all is that relationship management piece. But we want to keep the students engaged using our app. So this is going to be living inside an app effectively. And how to have it where they're using it on a daily basis, it's almost like a daily vitamin they take, where they go in, they do these positive psychology exercises, which are assigned by that counselor. And basically, it's a way also to keep continuing engagement with the application. And therefore, the counselor can detect changes over time.
Yeah, so let me add that when the student starts using the application, that student will take a screening, a mental health screening. The psychologist or counselor will get that result, which will basically set like the level of risk that the student has. And then the counselor can assign that a student like an action plan and games and activities that are based on the principles of positive psychology. So we're not just planning to give the student a test. We're planning to follow the advancement of that student while the student is in school and see how he or she is progressing, if that answers the question.
Is this platform intended to be on the mobile phone or the smartphones for the students? And what's the penetration in public schools in Colombia of that? And the second question is, what's the evidence base behind positive psychology?
Sure. So the Optimista will be app-based and desktop-based. We have a 59% penetration rate in Colombia, and Mark Zuckerberg just launched internet.org.
Is that kids or is that total?
Oh,
the 59% is
total,
overall.
and 99% of the schools in Colombia have internet, public schools and private schools. Is something that the Colombian government is very serious about. Mark Zuckerberg launched internet.org in Colombia, the second country after Zambia. So right now, low-income Colombians have access to the internet through this platform.
I'm sorry, just to answer on the positive psychology aspect, Martin Seligman, who's the founder of positive psychology, he's at the University of Pennsylvania, He created a whole program, multi-million-dollar program with the U.S. Army, which has had dramatic effects in reducing the suicide problem in the armed forces. So I think that right there is a fantastic testament to what you can do with a positive psychology program to having real effects on people's lives.
Are you thinking that the real value here would be to baseline students over the course of their career and then alert appropriate people? Or are you thinking that just using the app in itself is sort of the significant benefit outside of sort of the alerting and bringing in people, or, you know, raising the situation?
Sure. So positive psychology will allow the counselor to complement the work they do with the students. And for the students that are okay, it allows for prevention of mental health disorders. So we see it as a tool to empower the counselor, you know, so the counselor can be more effective and can actually detect which students are at risk, who needs help, and if the interventions they're trying with these students are actually working.
So again, these are going to be, you know, multiple choice answers to questions. I'm just trying to figure out how the students' answers get tabulated into this person is in danger, whereas this person is not.
You can answer that.
Sure. So that's you're asking about the screening test. So the screening test has been used in schools, universities all over the U.S. and Canada for about several decades now. I know Dr. Davis is a very similar offering, but he's more focused on primary health care versus the educational sector.
I was more talking ongoing, like as the students use the app on a daily basis, how do their answers?
So the screening is actually very, very quick. It's about 20 questions. You answer it fairly quickly. And it's designed to be, again, it's designed to detect risk, not diagnose. It's designed to say you have low risk, you have elevated risk, and effectively be able to show you, let that counselor see the overall risk profile of their student population.
So this is a look and figure. So they will basically
Thank you.
feel like games, basically.
So Sias is up. Time?
Good evening. I'm Dr. Alan Goodwin. I'm a psychologist. 1961, walked into a very large state hospital in Tuscaloosa, Alabama with 5,600 patients. Nobody knew what technology was. It wasn't a word in our vocabulary. Fast forward 50-some years, met Alex Zieg. We started talking. He's a tech guy. I'm a clinician, an idea person, and we started talking about telemental health, looking at video conferencing applications, started a company called VEH, which got taken over about a year ago. Anxiety disorders, rampant, overwhelming, millions of Americans confronted with anxiety, a lot of different anxiety disorders. My own son, OCD, fear of getting HIV when he was about 21. In retrospect, he had had symptoms of OCD for a number of years. After a lot of battles and not doing very well, at age 24, he found Edna Foe over at the University of Pennsylvania Center for Anxiety and Dr. Seth Gillum, and just did tremendously with exposure work. So I'm a total believer, even though in 1961 we were involved in CBT, I really now see the value of it. Problem with exposure therapy, some of the challenges, the two major processes used with exposure work are imagination, with certain individuals who really can't concentrate, not always effective. Going out into the real world, my son got sent out into the real world, that was great, but if you, let's say, have a fear of flying, it gets rather costly and maybe not very efficient to really start getting on planes all the time.
So what does that bring us to? 20 years ago, virtual reality was pretty much what you see on the screen. Heavy wires, big contraptions, stuck to a computer, things like that. Fast forward to 5 years ago, not much has changed. You're still essentially the same contraption, maybe a high-def screen, not much is different. Last year, 2 years ago, Facebook buys Oculus, $2 billion. Things that just got released at CES, HTC Vives, high-def screen, virtual reality systems, mounted on your head in a very, very small system, something small enough like this right here. So again, virtual reality has come a long way. It's high-def, it's effective, and it's completely immersive. Couple big things about that. The mobile applications that really make a difference, because instead of now being tethered to a computer, you can run this application directly from your phone. So you program in the software, put on a hardware overlay such as the goggles, and you have a fully immersive 3D environment.
The implications are the marketplace in terms of being really open to a larger mass market. In our conversations and relationships, Chrysalis in South Florida, the largest public mental health operation in that area, Broward, Dade, and Palm Beach counties, they're very excited about the potential to use this. Hospital and Health Corporation here in New York City, and their mental health component, they see the possibilities. Karen Renaissance in Boca Raton, Florida, opposite end of the cost factor. Sid Goodman and his people very excited to do a lot of experiential work, and a lot of things they're starting to do now. This fits in perfectly. The total market size, 1.6 billion potential users with anxiety disorders, specific types of phobias, fears, and a huge possibility here. We have to emphasize that this tool can also be used for some degree of differential diagnosis. This is fully operated through clinicians. This isn't an open market sort of device where our customer base are clinicians and clinical institutions. In terms of that, our targets are private practice clinicians, community mental health organizations, community health organizations, inpatient and residential programs, and I do again want to emphasize we're talking about both mental health and addiction treatment programs. We have about 90 plus physicians now, or clinicians using it, currently using it. They're using it approximately 2.4 times per week. We're really getting tremendously positive response. Out of time.
Are we done with time?
Yeah. So you're into your question time now. So
okay.
Let's speed it up. Maximize questions.
Oh yeah, let's just go right to questions.
Yeah.
Let me summarize quick. Again, what it is a 3D anxiety treatment disorder that runs on a smartphone app that's put into these goggles, which creates a completely immersive experience. It's sold to clinicians and therapists right now, and they operate it with the patients that are at their side. And they get fully automatic report printout that collects certain various biofeedback mechanisms and accelerometer axes on this.
What's it cost?
Cost right now for the hardware is $150, and we're selling subscription models to the therapists at $10 per session on an ongoing monthly cost. One of the other things is because it's software, is we can customize the session. So right now we have 9 different scenarios that we can customize, and we have different event triggers within each scenario that has certain things happening. For example, in the fear of flying scenario, will trigger. Sorry about that. In the fear of flying scenario, we'll have these different event triggers that can occur, such as turbulence. All of a sudden, the surroundings would look like you're going in turbulence. Trigger night, trigger takeoff, things like that. So we have a lot of different ways in which we can customize these scenarios for the different therapists and their patients.
Does it work?
It works. Like Alan said, we have over 90 doctors using it in Spain right now. We're partnering with Yale, University of Yale Medicine, Medical University. We're partnered with University of Southern California. They've done clinical studies. It's exceedingly effective. And as Alan said, we're working with a couple very, very large community mental health centers in the United States to roll this out.
I know with other virtual reality systems you get nausea, so you guys how have you overcome that?
Right, so really what you're looking at is about a 22 nanosecond lag. As long as you're under that lag time, you should be good, and so far we're very much under that. Now, I wouldn't suggest using it for extended periods of time, such as 2 to 3 hours, but for the sessions that last usually about 10 to 15 minutes, we don't seem to be experiencing any of that nausea.
And you may have covered this, how much therapy or treatment is required to settle a phobia on average? Obviously, there's discrepancy patient to patient.
Yeah, I think as you just indicated that there is a variation depending on the patient, but generally this is used 5 to 10 sessions, and again, it's an adjunct for the work that the therapist is doing and with exposure therapy.
So exposure therapy works fairly well with highly motivated patients. However, this quote of 1.2 billion potential market size, most people with spider phobias and plane and heights and things like that don't get any treatment at all. They just deal with it. They avoid spiders and they don't go on planes and so forth. How would you, it just seems like a very small niche of people who actually seek out treatment. How would you expand that?
Well, it's the niche of people who end up in a doctor's office. And again, I'll use my son as an example, who, again, his fears became completely overwhelming. He was not functioning, this very bright, highly motivated kid. And there's data out there that suggests that, again, if a therapist is really trained to use this, they can direct this. A lot of those other fears, sometimes people end up in treatment for a variety of other reasons, and that comes out, and this is another good adjunct.
I think we had 2 questions from the crowd, if that's allowed.
That is not allowed, I'm afraid. So,
Okay.
Well, from the judging panel, 1 question here because we have 1 minute.
Okay.
But questions from the audience needs to be during network.
So, I understand the technology is new in that it's inexpensive, which it never was before, I guess, and the quality, I haven't seen the Oculus myself, but I understand the quality is very good. There should be, so because of that, there should be a lot of data, even though the systems were bulkier and more expensive, this has been done before, and you should have a lot of data on how well it is.
Right, so exactly what you're saying. The technology has been around. Really what we've done is, much with phones, we put them in our pocket and we made them mobile and accessible really anywhere. And the data does exist for virtual reality therapies. There's about 20 years of very reputable studies that have backed up and shown that it is effective. So there is a good amount of data out there.
The new thing here is that it's cheap. Is that really
It's cheap, it's better quality, it's much more accessible. In the past, of all this bulky and expensive stuff, the utilization really wasn't very high.
Right, and
even the numbers were
right, and the other thing is that it's written in Unity's Unity engine, which is always being upgraded, and you're always going to have best and best, right? The last thing I would say is that we've raised $400,000, and we've been successful and written up and profiled by a number of successful companies.
Okay, thank you very much.
Thank you.
Hi, everyone. My name is Ryan Villanueva. I'm a search and rescue volunteer, a former EMT, and a business person turned an Angular node developer. So all you Sternies take note, it's possible to do code as a business person. So I believe that we can use mobile gaming as a platform to help treat depression. We can do so by making the first step towards treatment a lot easier. We can provide early access to support and assistance, and we can collect a huge amount of data that can be used for further care. So you've heard a lot about how important depression is, and I think we all know that anecdotally from our own lives. Mental health, we spend the US $147 billion a year. Interestingly, over the past 2 decades, the amount of antidepressant use has quadrupled, but the amount of psychotherapy use has slightly gone down. And that's not because psychotherapy is any less effective now than it was before. It's because, again, sometimes it's prohibitively cost ineffective. You've seen the data about computerized and gamified CBT being potentially similarly effective to face-to-face therapy. Not that it should replace it. But there are companies that have done this before. You heard about the one in the UK, Beating the Blues. There's Lantern. But again, it's that stickiness issue. How do you get people to actually use it? I think I have an answer. So when you read fiction, you fully immerse yourself in the story. You suspend your disbelief. And there's something really, really powerful about that. In the Courage app, we embed therapy lessons in meaningful, emotionally truthful stories. In doing so, it makes it a lot more accessible to people. In this app, we pose questions that are thought-provoking, diagnostic, and meaningfully woven into the story. And we can get data out of it that's really interesting. Based on that, the world adapts to you, and it makes it uniquely theirs, both in a data-driven way and in a story way. You're able to identify key elements and respond in your own way. As you grow, the world grows with you. Throughout the journey, curated content intersects with anonymized content from real users, introducing them to relatable stories and inviting them to interact. This also has the benefit of creating an anonymous support network. This game isn't just for people who need to get help. In fact, one of our main messages is that this is also for people who want to learn how to help others. It's an incredibly underserved audience. By focusing so much on getting treatment for people, we forget that this is a huge burden, and there's a lot of confusion on the part of loved ones. By taking the role of someone trying to help others, we can teach simple but critical skills like how to listen non-judgmentally and understand some of the underlying causes of mental illness. The wonderful thing about this is that this two-sided approach is that it also destigmatizes therapy. Because in the beginning, it can be easier to tell yourself that you're trying to help someone else than admit you have a problem. And really, this is stuff we should all learn anyway. I think there's something really, really compelling about looking introspectively and figuring out what your core beliefs are and how you view the world. Lastly, Courage is a platform for care providers that unlocks access to patient, new data sources, and modes of interaction. We believe that we can provide enough value that this can become a primary mode of patient-provider interaction and charge a percentage plus a premium subscription for additional features. There are a few important benefits for providers. We can gather a variety of data, both unstructured responses like journal entries and structured responses like diagnostic questions, and integrate data such as Fitbit and iOS HealthKit to analyze that and then provide curated content, but also inform the provider how to better provide care. We've also created a large community of users inherent in the app, and we want to change the mode from where people at risk have to reach out to us, rather us being able to proactively identify and reach out to them. Care providers, through this, can integrate themselves in the story and unobtrusively suggest further care. Finally, we provide a new method for care providers to interact with patients. We seamlessly integrate therapy homework and customize data collection into the story and structure of the game based on care providers' preferences and how they run their therapy. By doing so, we can improve treatment retention and compliance. I believe that there's a way for a beautiful blend of art, science, and big data to come together to solve a major problem. Clinical evidence suggests that it's possible. We just need someone to create a good enough game to do it. Thank you.
I think you referenced sort of crowdsourcing the responses and sort of dynamically building the stories. Is that engine, or has that been defined clearly how it fits into this project, or is that just sort of a concept?
So let me make sure I understand your question. So how do people interact with other people, and how do they tell their own stories? Is that the question?
Yeah, I'm struggling. I understand the concept. I'm struggling with how that
Fits into the treatment.
fits into this treatment.
So, I mean, in CBT, for instance, you have to record your own thoughts and as part of the homework. You're doing that, and then if you're sharing with others, you can interact with things that other people have created. And I think there's something really powerful about being able to see and relate to someone else's story and then use that as a point of connection. And that's the power of anonymous support networks. Does that answer your question?
I think so, yeah.
Great.
So is the revenue model subscription, or can you tell us what it is? And the second thing is, so if you want the care providers to be very involved in this, what's the incentive for them apart from the altruism, but like how do they get reimbursed for that?
It's a good question. So I didn't want to go fully into this because this is something we're exploring around the legal implications of. But right now, you have crisis support lines. That's the base level of care. You interact with them. It's a short-term transaction. Trained psychologists, that's a long-term transaction, a big commitment both financially and time-wise and emotionally. I think there's something in the middle. And there's a lot of recent movement around peer support specialists. And I hate it when people use analogies to other companies, startups, but I'm going to do it anyway. So in the way that Uber unlocked this whole new source of taxi drivers, I think we can do that with someone in the middle, like a peer support specialist. And I think that's a hugely powerful thing when you have a really short supply of care providers. And then to answer your question, the revenue comes from charging a percentage of when they use this as a platform to connect with that middle care provider.
So this, I think, has the potential for getting very strong support from a number of patients. People who, just the whole story metaphor, I think, speaks to me. I'm listening to this, and I can think of patients that I treat now who would really get into this and find this to be extremely helpful and useful. So I applaud you for the design and kind of the beautiful quality and so forth that you're working on here. So that's really great. This concept that you just now said about peer support specialists, I think that the healthcare industry, particularly mental health, is increasingly starting to embrace peer support, people who have lived experiences with these conditions and can help others. And my patients who have done that sort of thing, they find it to be very personally powerful for them, and they grow from it. But also, I think patients, we talk about stigma, and when you are working with somebody who's been where you've been, they just are much more engaged.
Thank you.
So is the product ready to go? Do you have development to do? Where are you in the life cycle of the business?
I'm building things, prototyping. I want to get one of the nice things is I'm a jack of all trades, master of none. So I want to get this model right, and I want to test the storyline with people. Once we have that, we can go full-fledged and start using people's money.
You said I a lot, so is it you, or do you have some, who are your content experts that are helping you with the story and things like that?
Yeah, in the terms of the building, I've drawn a lot on subject matter experts to get their advice on, but the core of the initial prototyping is me.
You talk about the prototyping. Have you, at least wireframed something, flashcard version, web
Yes.
version, and actually had people utilize it and gotten any significant feedback?
The real prototype beyond what you see here is really ugly, so I didn't show it here. Yes, people are starting to use it. I'm starting to work through it. This is a really core, like, hey, will you write stuff down for me to this prompt? And people seem to like it. I mean, it's early. Well, I hope that's a good thing.
Okay, thank you very much.
Thank you, everyone.
My name is Jessica Minhas, and thank you guys for sticking around. I know this is like the last presentation of the evening, so thank you very much on behalf of myself and everyone we hope that we hope to help. So I'll go first. You're probably asking, what on earth does that mean? Now, just as an anecdote, anytime that I talk to people and I'm like, yeah, so I run this organization, it's called I'll Go First, they're like, what? And I'm like, I'll go first. I will go first. So it becomes this like almost experiential time for both the person I'm talking with and myself, But so I'll go first. So my background is in trafficking. I've been working with survivors for the past, I guess, about 12 years now. And not only on the advocacy side, but also on the empowerment side. Now, when I first started, I had no idea what I was doing. I was actually, just a sidebar, I was actually adopted, raised by Germans who were abusive. So I have my own story. Not only am I in startup mode as a CEO, but I'm also a user. This is something that has come out of my own personal experience, trying to figure out the nuances of my story, deal with my trauma. I'm not the only one in the room that has a little bit of trauma and junk in the trunk. And what I kept finding was that, anyway, so I was raised by Germans. I went to India to try and find my biological family. I didn't have their names, so that didn't go too well. But I did learn about sex trafficking for the first time. And what really struck me was this shared vulnerability and this shared experience of abuse. Now we know that in the trafficking space, I think it's like 85%, and mind you, these statistics vary a lot. It's a black market. So we do the best we can with the statistics, but about 80% of these survivors have experienced some form of trauma. They're chronically abused at home, they're sexually abused, whatever else. And not only was that happening abroad, but then I came back stateside and I was working with domestic survivors. And shockingly, you guys probably are not surprised by this, but they also had this history of trauma. And I started wondering, okay, is there a way to enter into somebody's story, into this like vulnerability gap, before someone is exploited? They have all the abuse that's happened. Could we enter into someone's story and say, yes, and there's more that can be possible for your life? And how do we do that? So my experience led me to speaking a lot in public about this, very happy and uncomfortable issue of sex trafficking. And often what I would find is that afterwards people would come up to me and be like, oh my gosh, I'm so glad that you're talking about this because I just need to tell you that blah, 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 right? So those of you who are in the helping fields, you probably get this too. The minute somebody finds out you're a doctor or a psychologist, they're like, oh my gosh, I'm so glad that you're having this conversation with me. I've experienced X, Y, and Z. And I started wondering, okay, but we're in the States and they have access, hypothetically, they have access to get the care that they need. So how do we provide a basket for them? How do we provide an outlet for them? And that's where sort of I'll Go First came about. So our mission is really to provide a safe place for someone to get it off their chest. Now, what do I mean by that? Now, when I talk to audiences and I say, and they tell me their story, I always say, that's great. Why don't you share it on allgofirst.com? It's just, at the moment, it's in beta form. It's just a storytelling platform that we say, hey, share what's on your mind, and then we'll connect you with services that can help you. Because we know that we can't always be the emergency services for somebody. That really needs to be people who can be on the ground and assist them immediately. So how the platform has sort of developed is, gosh, I talk a lot. So how the platform has developed has moved from, when we know all this, all the issues about trauma and whatnot, has moved from not just a storytelling platform, but really to a space where we can provide online access to mental health. So CBT, positive psychology, trauma-based therapies, social emotional learning. We're actually partnering with the Yale Center for Social Emotional Learning, and we're partnering with the Allender Center, who specializes in narrative therapies, to really say, hey, you guys are the experts. Let's partner together and try and figure out a way to reach people right where they're at in a way that's safe, discreet, non-stigmatizing, we all want that, and in a way that really helps people. So we see ourselves as sort of the shoulder to cry on and also the counseling coach, if you will, to say, okay, you've started this journey of counseling, we've entered into your story, into that tiny, tiny window, that gap, where people consider getting help, and then we really want to support somebody through that entire journey. So it's really a support system to be able to do that. This is Christopher Schwartz. He's actually my co-founder. And yes, okay, great. We can go into questions. I'm just seeing if there's anything further. We're still trying to figure out our business model. At the moment, we're looking at enterprise and all of that. And partnerships. We have a lot of competition, but that's a good thing because we all know that it's going to take a hell of a lot of people to try and figure this out.
So it's a neat concept, right? Trying to create this first step into the mental health space for many people who may not be aware of it. It seems like the big challenge here will be awareness, generating a knowledge or a brand out there such that when people discover that I need services or I need help or I just need to get something off my chest, I'm going to go to I'll Go First. Marketing seems to be more important here than perhaps the other companies that we've seen today. How do you think about marketing?
Yeah, and I think both of us can answer this question. My background, like I said, my background is really in the trafficking space, so we're already starting conversations with the World Health Organization, the United Nations, different various trafficking organizations that are really eager to sort of have this basket of storytelling opportunity for their constituents. And we see ourselves as sort of a go-between for those different nonprofits and whatnot.
Hello. And my background is actually in marketing. I've been in advertising, brand strategy, and product innovation for the past 8 or 9 years or so. So that's very much been kind of my emphasis of what's the brand story, how do we become that soft entry point for those that do have kind of more of a traumatic backstory, or even those that don't realize that there's been incidences in their life which has inhibited them from really excelling to live out their full purpose. So really, pinpointing those individuals and, as Jess said, targeting the universities, and the various networks through partnerships that we have currently.
And then, of course, media.
I think awareness and advocacy, I think those are some of the strengths that you have with this sort of storytelling model. It's unclear to me, though, how patients are going to get individualized help from this.
Yeah.
And I see that you're working that out.
Mhm.
So I'd like to hear a little bit more about some of your early thoughts about that. And the other point I wanted to make is about trauma. So I work in Baltimore, inner city. I see patients 2 days a week. And while none of them have had what I would call, I guess, trafficking, the way you talk about it, more than half have had severe traumatic experiences, usually sexual abuse and as a child and even as an adult, particularly as an adult because of substance abuse issues. And they get so addicted that they wind up prostituting themselves.
Mm-hmm.
So I imagine that that's also what you're going to be going after. And I know that my patients would love to have some sort of way to get their stories out there if they felt safe. So I also want to hear something about security. And this is very sensitive information.
Yeah. So we actually, we soft launched really quick. We soft launched in November. And then, of course, my engagement with different trafficking organizations, domestic violence organizations, and child abuse organizations sort of had started sending their constituents to us, which has been great for us to sort of learn what the user is really, what they really need and what they're really looking for. So what we're finding is actually we're having this segment of millennials, strong millennials that have experience with sexual violence that need online engagement right away. And so what we're playing with is a coaching and mentoring type service. And of course, we say trauma here, but we're relaunching the site in July, and the trauma narrative will sort of be wiped away, and we'll say, hey, life happens, share, get it off your chest here, sort of to really speak survivor type languages. And then we also have this growing segment of older women and men who are starting to engage with the platform. And so we're experimenting and trying to figure out, okay, what is a way that we can engage with them that also makes them feel safe? And that's ongoing, an ongoing process.
And so from the privacy perspective, everything would be obviously very lock and key. And then when there was concern from a risk, a health risk of the individual, say if it was severe depression, then we would have local on the ground connections to plug them into to make sure that all's.
And that's actually part of our partnership with Aunt Bertha. Has anyone heard of Aunt Bertha already? They're a social service, Google. Okay. So really cool.
One question here. Yeah. All right, then we'll call Todd. Okay.
So I understand the entryway and the main focus, and we've talked about is people sharing their stories. I understand the value in that, and that's compelling in a site that's focused on that. The rest of it is very unclear, and I just want to give you one more chance to say A, B, C, D. This is how you envision right now somebody stepping through the site as clearly as possible.
Okay, thank you. So we have 3 tracks. One is the story track, and then we have a heal track. And that's really where you're going to see the cognitive behavioral therapy, the positive psychology, the engagement with the user from our team of experts that are sorting out what that curriculum and those engagement types will look like. And that will be off of like an upfront diagnostic and then a back-end diagnostic and that type of thing. And then the final component will be a purpose component, which is really sort of walking somebody through what it means to live on purpose beyond their therapy. We're not trying to make people professional survivors. We want to partner with them in their self-emancipation.
Okay. Thanks. All right, thank you very much. Thank you. Okay, so those are our presentations. Very nicely done. So what we're going to do now, we are going to take actually a 10-minute break because the judges need to kind of review and calibrate their scores. Then we have to get them plugged into a spreadsheet to add them all up. So I'm going to ask you to, network more, use the restroom. There's more food back here, and we'll come back together in 10 minutes, and then we'll announce who the winner is, okay? Variety of solutions, really good business cases, and I'm going to tell you, and I'm sure others in the room agree with me, that we're so appreciative as a community. What I'm going to actually coin us the digital mental health community. for the work that you guys are doing, the business models you're putting together, and look forward to continuing to be in touch with and working with each of you as you continue to prove your business models in the marketplace and scale them up. That being as it is, there can only be one winner at the end of this contest. And so what I want to do is state the first runner-up and then the winner, okay? All right, so our first runner-up is Courage Health. Okay, so thank you very much, Ryan. All right, okay. And our winner of the Mental Health Digital Innovation Challenge $10,000 prize is SciAS, virtual reality. All right, and so Alan Goodwin will be accepting.
Okay.
And then Anthony.
Congratulations, SciAS. We're going to award you $10,000 check in cash and prizes. Okay, so we're thrilled that you won, and we think you have a great opportunity. And we want to thank our sponsors who put all of this wonderful effort into this event. Dudnik, thank you very much. We also have Janssen Innovation. We have Haven On Demand HP, and Sana, if you want to stand up, is here from HP. And she has a tablet, HP tablet stream that she's going to give you. And she's also going to be happy to consult with you in terms of their data services and see if they can help you in any possible way. If it makes sense, they'd be glad to do that. Okay, so we were thrilled, and we will make sure we arrange all of the cash and prizes to go your way in the very, very, very near future.
No cash today?
Yes, no cash today. No cash today. Okay, so most importantly, thank you for what you're doing and helping the mental health effort and cause. It's critical, and that's why we're all here today. And do you want to say anything?
Thank you. First of all, your panel of judges, the questions were great. The diversity was great. People that I've interacted in the audience, just their interest has been tremendous. I do want to say that Ryan and the Courage, I really thought they won. What he's doing is wonderful. Everybody's presentations were great, but tremendous evening. Thank you.
Okay. Thanks to everybody. Also want to mention MedStarter is the #1 healthcare crowdfunding website. They've been a sponsor of these events for years. So if you need another alternative way to raise money for your startups, please consider MedStarter. You'd be more than happy to talk to me or go to medstarter.com. They do incredible jobs. So many people have presented at these events that have gone on to have incredible success and sell their companies for $54 million plus. So, you know, have faith, keep going, keep demoing, keep selling. Let's change this healthcare world for the better, okay? And we're going to have an after party if you want to continue to network at West 3rd Street between Mercer and Mimi. Where are you? Help me. Where is it? 1 West 3rd Street? Okay, 1 West 3rd Street is the bar. We're going to be over there in about probably 15 minutes. So there you go. Okay. And keep following us on meetup.com. And I want to thank all of the wonderful volunteers tonight. I want to thank Craig DeLarge for this incredible project. Mimi, Rachel, everybody. Mike Schwartz, our videographer. Thank you, everybody. Judges, great job.